Hey, we're going to get started and kick things off. So I know we're still having people come in, but I'm just going to get going as people find seats, okay? So good morning. It is my pleasure to welcome you to the first session of our 2022 Women's Health Cancer Conference. So my name is Jessica Sintolo Gonzalez. I'm a surgical oncologist and the co-chair for this year's event. Before we begin, I do want to just give out a few housekeeping notes. So we are encouraging people to wear masks when not eating. Please silence your electronic devices, and we will be circulating a microphone for questions at the end of each session. This is a hybrid event, and we're thrilled that over 300 people are also joining us virtually. So for Zoom attendees, you can chat your questions in as you're listening to the sessions, and a volunteer will read them out loud during the Q&A. Lastly, if you have signed up for continuing education credits and have any questions, you can check in with the CMIE team at the registration desk or look for an email on Monday. All right. So now with our first session, it is my honor to introduce to you Dr. Randall Holcombe, who is the host of today's panel, New Technologies to Reduce the Burden of Cancer. Dr. Holcombe is a medical oncologist. He's the director of the University of Vermont Cancer Center and has really been a visionary in where he wants to see that cancer center go. And he is a health services researcher. We know you're interested in learning what's new in the field, and this panel is all about where the science is going in the future. So thank you so much for joining us, Dr. Holcombe.
Thank you so much, Jessica. So this session is entitled New Technologies to Reduce the Burden of Cancer. I think it's going to be really exciting. I want to tell you who our panelists are up here. First, James Gerson, who is an assistant professor of medicine in the Division of Hematology Oncology. He received his medical degree from Case Western Reserve University School of Medicine, did some postgraduate training at Stanford and Fox Chase, and is coming to us from the University of Pennsylvania, actually started here at UVM about 2 weeks ago. He's going to be serving as director of our CAR-T program, which you're going to hear about in just a few minutes. We've also got Dr. Nikoletta Sidiropoulos, who is an associate professor of pathology and laboratory medicine here at the Larner College of Medicine. She's the inaugural medical director of the genomic medicine program here at UVM Medical Center. She received her medical degree from the University of Connecticut School of Medicine, completed residency at Dartmouth Hitchcock Medical Center with some additional fellowships in cytopathology and molecular genetics. Her expertise is on molecular genetic pathology, and she's going to talk today about new innovations in genetic testing for cancer. And we've got Dr. John Shepard, who's a professor at the University of Hawai'i Cancer Center. He's visiting us today. He's a Fulbright Scholar, a fellow of the American Institute for Medical and Biological Engineering, former president of the International Society for Clinical Densitometry. He received his PhD in engineering physics at the University of Virginia, did some postdoctoral fellowship in biophysics at Princeton University. He studies body composition, bone density algorithms for women's health, and he spent much of his professional career in the radiology department at the University of California at San Francisco before he moved to Hawaii. He's interested in biomarkers for breast cancer, and he's going to talk today about artificial intelligence and how that can be utilized to help in breast cancer screening and to reduce the burden of cancer. So I'm going to have each speaker talk for about 10 minutes. We're going to just go rapid fire through the three of them. So save your questions or write them down on the paper that's on the table in front of you or at home. And then we'll have plenty of time for questions after that. I'm sure that the talks will stimulate lots of questions. If you're at home looking at following this on Zoom, put your questions into chat. We will monitor them, and we'll try to get to all the questions at the end. We're going to start with James Gerson.
Thank you, Dr. Holcombe, and really such an honor and pleasure to be here. I'm I'll be honest, I'm mostly just relieved that I found the Davis Center this morning because, as Dr. Holcombe mentioned, this is the end of my second week, and I've never been in this building before. So glad I made it. So I'll be talking to you about chimeric antigen receptor T cells, CAR T, as it's commonly called, which is a very exciting treatment currently for hematologic malignancies such as lymphoma and leukemia. But there's a lot of hope that this may someday be a treatment option for patients with a lot of other kinds of cancers. These are some disclosures. So because the audience, I think, consists of a wide variety of some patients, some caregivers, some lay public, and also providers, I thought I'd just give a very general overview of what we're talking about here. And so what I tell my patients is that CAR T cell therapy involves harnessing the immune system to target cancer. And it's taking a normal kind of cell in the body called a T cell, whose job it is to survey the body for infected cells, usually with viruses, and to kill them off. And so shown here is a normal cell that might get infected by any virus, such as COVID-19, but lots and lots of other viruses even before the pandemic. That cell would be infected with a virus, and the cytotoxic T cell at the bottom would come in and identify that cell had been infected and engage with it and then kill it. And there is a role of T cells in surveying the body for cancer as well. And it turns out that the immune system is able to kill off lots of different types of cancer that might develop in the body. But the cancers that grow to become clinically relevant are those that are able to evade the immune system. And so the immune system has a much more limited role once you're diagnosed with cancer. And so what we do in this CAR T cell therapy is we take those T cells that normally are targeting viruses, and we engineer them through a very high level process to target and kill off the patient's cancer cells. So shown here, this is a very fancy animation put together by my colleague at Penn, David Porter, where using a lentiviral vector, a T cell is engineered to produce a novel T cell receptor. And the T cell receptor is what a normal T cell uses to engage with those the infected normal cells with virus. That novel chimeric antigen receptor, which is where the name CAR T comes from, goes to the surface and allows this new engineered T cell to engage with and kill off a cancer cell. This is a very involved process that involves taking immune cells out of a patient, sending them to generally a company, although there are some institutions that are doing some investigational products in their own walls, and doing the engineering process, which takes somewhere between 2 and 4 weeks, although there's some new technologies coming out, maybe bringing that down to just about 2 days, and then putting it back into the patient, hoping that we'll then target and kill off the cancer. And currently, CAR T cell therapy, which was first FDA approved in 2018, is approved for a wide variety of hematologic malignancies, mostly lymphomas, some leukemias, and also multiple myeloma very recently. And as I mentioned before, there's a lot of interest in bringing this to solid tumors as well, so breast cancer, prostate cancer. So there's an unbelievable number of clinical trials that are currently open across the country in solid tumor, as well as other blood cancers not listed on the slide before, hoping that we can really expand this and bring it to patients, a wide variety of cancer types. And what's really novel about this is, there's lots of therapies that are very advanced and scientifically very interesting. But what's really amazing about this one is this is really a living, breathing treatment that goes back into the patient and lives with them for years. The longest survivor after a CAR T cell therapy was still alive 10 years after he received this therapy and still had those CAR T cells in his body. And that's unlike any other therapy that's ever been given before. So very exciting, and really such a pleasure to be starting a new program here at UVM to offer this therapy for patients who need it in the area.
Thank you, Dr. Gerson. I'm sure that stimulated questions, so write them down because we're going to get to them shortly. Next up is Dr. Sidiropoulos, who's going to move from T cells to genetics.
Hi. been a long time. I think the last time I was up here, it was before the pandemic keynote. So it feels like brand new again, speaking in front of people. So we have a sunny day, right? A little crisp in the air for fall. So my name's Nikki Sidiropoulos, and today I'll be talking about liquid biopsy. So what does that mean? Instead of tissue-based biopsies that a lot of us are familiar with, instead we want to leverage fluids, things that are not tissue, if you will, from the body, and try and look for biomarkers. I'm a molecular genetic pathologist, so I'll be specifically talking about genomic detection of tumor DNA. So liquid biopsy, specifically using the blood today, and to look for tumor shedding its DNA, and what can we detect in the blood instead of using tissue. So just to give a little bit of background, not everybody is familiar, right, with genomics and DNA and testing for mutations in the DNA. And so nucleic acids were first described in the blood actually in the 1940s and it was in the French literature. So I haven't read that primary literature because I don't understand French. And then in about 30 years later, Leon et al. As a group was actually able to detect, that group was able to detect DNA in the serum. So that's part of the blood in cancer patients. And so what they were able to determine by the 1970s was that a dynamic, that the DNA in the blood was actually a dynamic biomarker that would shift in concentration depending on the patient's clinical state with their cancer. And then fast forward to the 1990s, right, where molecular diagnostics, and that's my field, so using DNA, RNA, things of that nature, and studying them to generate a clinical report that could be used for clinical care, molecular diagnostics actually emerged with a critical role in molecular biomarker detection for clinical care. And so in 1992 and 1993, even up to 1994, right, they started to detect, researchers started to be able to detect these cancer-specific mutations in genes in things such as the stool for colorectal cancer, in things such as sputum, so right, something you spit up if you have lung cancer. And so moving forward from the 1990s and all those discoveries that were being made, it really paved the way forward for emerging clinical applications of cell-free DNA that's been seen over the past several decades. And so currently, you know, from the 1990s moving forward, the FDA actually made some approvals for molecular biomarker tests. And when the FDA, I think, steps in and makes an approval, it's almost sort of a mark that something's here to stay. It's recognized at that level. And so in 2016, the first PCR test for EGFR mutations, that's a gene that's commonly mutated in non-small cell lung cancer that can be leveraged for therapy. Those mutations in plasma from non-small cell lung cancer patients, that type of testing was approved by the FDA. And then in 2020, a technology called next generation sequencing, which we use here, it's a much more robust genomic testing technology that can test for a lot of different biomarkers across a lot of different genes in one shot, right? One-stop shopping. Yeah. So NGS assays were approved for multiple therapeutic targets, so lots of different genes in the plasma, so using liquid biopsy from solid tumor patients. And this is not just one cancer type anymore. So really what we're seeing is that this technology is reaching an ever broadening population of cancer patients with every passing year. So what's the specimen journey, right? I like to think of the pathologist as really having a role in tissue stewardship. A lot of us get, you know, a sample taken from us and, you know, you just trust you're going to hear back, right? What's the answer? So what happens to your tissue, right, when it leaves your side? With cancer, you know, you have a lump or a bump, something that's suspect, and typically you undergo a tissue biopsy where a chunk of that tissue or cells from that tissue or that lump or bump are taken. given to the pathology laboratory. Anatomic pathology fixes them, processes them, and looks at them under a microscope. And so let's see here. Can you see my little arrow? No, you can't. What's the pointer? Do we know? This? So this is the tissue biopsy, right? And so that's what the tissue looks like under the microscope. But instead, now we're moving towards liquid biopsy. And so what does that mean? Tumors, just like tumor cells, just like normal cells, they have to have access to the blood, right? That's where they're getting their nutrients. It's where they're getting rid of their byproducts. And so tumors are constantly turning over, right? Just like a lot of other cells in our body. And so when they die, they basically dump out parts of their DNA into the systemic circulation. Sometimes even when they're alive, cells will package up pieces of their DNA, and that also can make its way out into the systemic circulation. And so with a blood draw, we can process that blood and separate the DNA from the tumor into a part of the blood and use that for testing. And so considerations for each specimen type. The key piece of information here is that the classic way of doing this, and the way we mostly do it now with tissue-based biopsy, is that you get to see what it is you're putting into your assay, right? You don't want to, you want to know what's going into your assay, making sure that the tumor is represented, because if the results come out negative and you don't know if you had enough tumor, then you risk a false negative, right? The thing you were trying to test wasn't there. So the negative doesn't mean too much. So with tissue-based biopsy, we feel very secure in doing that. All of us in the molecular lab are trained to also look at tissue under the microscope and make sure we qualify what's going in, because you don't want garbage in, garbage out. Cell-free DNA, the technology is evolving, but really what you're getting is an invisible fluid, right? That you can't see the pieces in there unless you use these very sophisticated detection mechanisms. And there are ways to say, okay, I feel confident that this is tumor DNA that we're going to test. It's just those technologies are maturing as we speak. The other key piece of information to walk away with today, if you're hearing about liquid biopsy and you're curious about it, is that it's not a one-size-fits-all model. There are different, there's obviously all of us in this room have a wide variety of tumors that we're interested in that are represented here today. And so different types of tumors are known to shed differently. So we have high shedders and low shedders. So this technology may work actually really well for some cancers and not so well for others, but being able to, again, the technology is emerging to enrich so that it can be a more equitable technology across all tumor types. Another thing, so we get now into this space where the life cycle of a cancer, what's the event and what's the treatment strategy? There's certainly screening, early interventions, right? You're healthy, but you're getting your screenings. Are there any early interventions? There's localized cancer where you detect it and you want to know what's my risk of dissemination and, what's the risk of recurrence? Then you get into a metastatic state where there's treatment selection and monitoring response to that treatment and these targeted therapies we talk about. And then refractory cancer, where now you've broken through that therapy. What is the mechanism of resistance? How did this tumor mutate in a way to create a new mutation so it could skirt whatever treatment you're throwing at it? What's that mutation? And now what's another targeted therapy we can go after it with, right? So you keep chasing it down. So these, we really have implemented liquid biopsy more so in that later stage, right? With refractory cancers, we could monitor them in that way. You know what type of cancer you have. You've already been in the treatment protocols. And so now you can just sort of monitor. Metastatic cancer, similar situation. Liquid biopsy does have a pretty robust role currently clinically in that space. But really, I think where this is becoming an emerging technology is the multi-cancer early detection assays. And so what these assays are is they're screening assays for relatively otherwise healthy people. And some of the claims, there's one company in particular in the United States that's gaining traction. And some of the claims that they make are, fighting cancer starts with knowing it's there, right? And approximately 70% of cancer deaths are caused by cancers without recommended screening. Another thing they like to talk about is, you can detect more cancers early when used alongside other mechanisms of screening. And then it's recommended for use in adults with an elevated risk for cancer, such as those 50 or older. So an age is a factor. And they like to tout that one blood draw can detect a cancer signal across 50 plus types of cancer. So that's pretty attractive, right? Because all of us would like to detect a cancer. That's why we do our screening, right? We all want to detect it early and take care of something if something's wrong. So what are the counterpoints to these multi-cancer early detection assays, right? They are intended to be used as screening tests. And in layman's terms, what these tests do is they tell your doctor that you may have cancer, right? The patient may have cancer. It's probably cancer X, whatever site in the body they determine, but we don't know where it may be, right? So, in a study with about 6,600 patients, healthy participants, there were 92 positive screens and 57 of them were false. The false positive results can lead to morbidity and sometimes mortality, and certainly psychological harms and significant costs. Something to be aware of is that not all insurance covers tests like this, right? So you might pay out of pocket, and that's fine. But if you get a positive result, you will be left trying to navigate the healthcare system with insurance that will not cover you because you don't necessarily have a diagnosis of cancer. And so imaging and trying to chase this thing down can be quite a costly thing. And it's crossing that divide right now that I think people need to have eyes wide open. And then I think lastly, early detection doesn't necessarily lead to improved survival all the time. And so I think right now they're claiming, well, we'll detect all these early cancers across healthy populations. You will do it early. But I think, even assuming, and I think it's fair to assume, honestly, in my opinion, that this technology is sound and could be considered a major advance, right, for how we use genomic testing in our cancer population clinically. But instead, I think initially focusing on at-risk populations, right? So for specific cancers where we don't necessarily have wonderful screening right now, pancreatic cancers, ovarian cancers, right? Focus on those populations. It might be a more efficient and effective way to identify potential high value applications that could allow for integrations into public health initiatives and into medical practice. So just my concluding remarks, and again, these are my opinions, professional opinions, but liquid biopsy is definitely here to stay. We're trying to move it into our laboratory here. The technology is not necessarily at a place right now where it completely replaces tissue biopsy. And then laboratories working on these assays for these multi-cancer early detection tests are utilizing remarkably deep sequencing. These are very highly sensitive testing technologies that are complex to detect cancer that's otherwise clinically not detectable, undetectable. And so lastly, clinical trial data will continue to emerge while preliminary data shows promise of clinical utility. Certainly additional data from large-scale, well-designed trials will determine clinical utility. And this type of testing is now incorporated into what Joe Biden had announced with the Cancer Moonshot. So if you're interested in reading a little bit more about that, it is worked into that with a massive clinical trial coming down the pike. So thank you for your attention and enjoy the next talk.
Thank you, Dr. Sidiropoulos. We're moving on to Dr. Shepard.
Good morning. It's great being with you in Vermont. It's a long ways from my current home. And it's nice to have go to a place where the weather's different occasionally. So yes, I'm John Shepard. I'm from the University of Hawaii Cancer Center. And I specialize in using and creating biomarkers for disease, using advanced methods that for the most part utilize artificial intelligence. So we might ask, what is artificial intelligence? And that could be a talk into itself. And all I want to say is that artificial intelligence is effectively a learning algorithm. And if you compare that to a normal like computer algorithm, normal computer algorithms do exactly what you tell them to do. They're deterministic. So they'll get the same outcome every time from their deterministic nature. Learning algorithms like artificial intelligence will look at data and will learn patterns that are there that you couldn't have even guessed. So that's why we call it artificial intelligence. It has this intelligence that it's bringing to the problem solving. The second aspect I want to emphasize about artificial intelligence is that it can utilize more information than we can as humans. And often their solutions to problems we call superhuman because they're beyond what we're able to do. And to give you an example, our eyes under the best circumstances can distinguish about 256 different shades of gray. And if you tried to see those on just a small, place card, you could probably only see about 8. But in the right conditions, you could see 256. And it's really unlimited what an algorithm could see, but we commonly use 65,000 levels of gray. So if a algorithm is a artificial intelligence program is looking at a mammogram or a medical image, it's looking at it with 65,000 levels of discernment. While when we visually look at it, we have about 256 the most. The third thing I want to say is that it's very complicated and it takes a long time and it takes a lot of data to train these artificial intelligence algorithms in the same way as it takes a lot of data and time to train like a radiologist. It might take 8 years to train a radiologist of medical school, then 4 years after that to specialize in reading images. But if you want a second radiologist, how long does it take? It takes 8 years. And if you want a second AI algorithm to accomplish not all the tasks that the radiologist does, but let's say one task, how long does it take to get a copy of that artificial intelligence program? Seconds. So that's why when you finally accomplish the goal, and I'm going to talk about several goals here. If you accomplish any of your goals, you can replicate that and spread that solution around the world immediately and do good things. But there are some downsides to artificial intelligence, and I'll talk about that at the end. So I'm going to talk about artificial intelligence within the realm of screening mammography. And the challenges really are finding the 5 cancers in the 1,000 women that are screened. So just to run through kind of the nominal numbers, if you screen 1,000 women for breast cancer, you'll have about 900 will be effectively ruled as negative right off the bat. The radiologists can discern that fairly quickly. In fact, in the old days when it was just films, it would take 5 to 10 seconds to determine a negative mammogram very accurately. But 100 of those women there might be questions and old films may be recalled and the women might even be recalled back in for further imaging. Of those 100, on average, about 25 might receive a biopsy, but only 5 of those biopsies will be invasive cancer, and only 1 of them will be advanced stage cancer. So the challenge is how can we better narrow that down to serve the women that are at highest risk and to avoid these unnecessary biopsies, especially when we have a national shortage in radiologists. The time it takes to do all these exams is very expensive. And so you could ask the question, is AI a kind of a panacea solution? And let's look at the roles that AI has been proposed in screening mammography. There's actually several. The first one is when the mammogram is available for reading, there can be a pre-read of those mammograms to select which mammograms are the most likely to have cancer and versus the ones that are the least likely. And then in many centers, you have a dual read setup where you have two radiologists read it to get a consensus view that's more accurate than one radiologist reading it. And often the AI program can act as one of the radiologists in that process. And to the right over here, instead of acting as a second reader, it can act as a reading tool to actually just help the radiologist when they're doing the reading. And then the final part of this process is after all the readings are done and you have all the images in your archive, you can revisit those images later if you have something more sensitive or maybe an additional marker that you want to look at the images with AI. You can recall all those images and AI program can do that. So the first example here is the pre-read. Here's an AI algorithm that can pre-read the mammograms, and it can discern which mammograms they think it has the highest probability of having cancer. So if you take the score that it gives on the left-hand side over here, it gives a score from 1 to 10, and you divide the population and put 10% of the screening population across the board here, you would find that over 78% of the cancers would be in the highest score, the 10. So the 10 is what the algorithm says this is the most suspicious category, and it puts virtually all the mammograms there. Now, when the radiologist in this study used this algorithm to read those mammograms first, when they're they've had their cup of coffee and they're all cheery in the morning, those are the mammograms you want them to read first, right? Not flipping through the 900 that are negatives. And when you do that, you find that every one of the radiologists improved in their accuracy. So the orange bar here is with the AI and the blue is without. So they improved their accuracy. But most importantly, if you look at this plot, you can see that to read these films that had the number 10 score, the most suspicious, it took them about 5% longer to read those. They spent more time on them. But on the ones at the opposite end of the scale, that was the least suspicious, they could spend a lot less time on them. So they're focusing their time on the mammograms that give you the most benefit because those are the ones that are the most suspicious. The second category is of the dual read. And this is a study where this AI program was used to highlight what the AI thought was the mammogram and digital breast tomosynthesis images. And if you've had what's called 3D mammography, it creates a whole stack of images for the radiologist to read, and they have to scroll through those, and it takes a lot longer. When I said it took 5-10 seconds before, it'll take 40 or 50 seconds for them to read these 3D mammograms. So that's a lot of time, and it can be fatiguing to go through case after case. When the radiologist didn't have the AI, their sensitivity and specificity is plotted here. And just to give you an idea, if you're not used to looking at these sensitivity specificity curves, this is perfect right here on the top left. That would be perfect. No cancers missed, all cancers found. And so when the radiologist had access to the AI program, you can see that it brought the low performing radiologist here way up to the top here. And this curve is just the raw performance of the algorithm by itself, because you can set its sensitivity at different levels. So you see on the whole, all the radiologists did better when they had this dual read, and they operated faster. The last thing here is that there can be biases in any algorithm. And in this case, we have the Breast Cancer Surveillance Consortium algorithm that's used for determining risk. And it's one of our most accurate algorithms that use clinical risk factors. And it can rate women as high risk or low risk. And if we looked at just the women that had invasive cancer within this study, it found that about 45% of white women that had invasive cancer were thought of to be high risk before the cancer was found. And that sounds like it's low, but if you look at Filipino, Japanese, and Chinese, only 10% of the women that ultimately got invasive cancer were considered high risk. So that means the model's not well calibrated for these subgroups of Asian populations because they weren't focused on in the model. But if you look at how AI works across the board compared to our clinical risk models, you can see that 5 examples here all give better performance numbers than the clinical model. And the only, if you're not used to looking at these AUC numbers, the higher the number, the better. So in all cases of either looking at cancers that were at the time of diagnosis, or the risk at the time of diagnosis, or even cancers that would 5 years after the mammogram was taken, the AI algorithms did better across the board. But there's this fairness and bias and explainability issue. If you just present a number to somebody and say, there's a high probability of cancer, and they go, well, what's that based on? I mean, how do I know that's accurate? Explainability in AI means you provide more information than just the probability of malignancy. You say we think it's that way because of these features, or we'll show you exactly where we're looking to think that it's malignant. And that helps the acceptance of the AI quite a bit. And the last part is fairness. If you use only data that's from white populations or from wealthy populations, often there can be this built-in bias. And in this example, the ground truth training here is bride. And so when you feed it through the AI algorithm, it predicts bride, dress, ceremony, woman, and wedding. But when you feed in another bride from an East Asian woman that's dressed differently, that wasn't part of the training data, it doesn't even come up that it identifies her as a woman. It says clothing, event, costume, red, and performance art. So it got the wrong answer. It's a bride that the answer is what you wanted, but it would never had that as an example. So this cultural bias can be burned into AI if you're not careful. So we're running a large registry in Hawaii to try to bring this fairness to AI training, to collect data in Hawaii on women that are of our region. 60% of the women in Hawaii are Asian and 20% are Native Hawaiian. And if we don't have data from them in our AI models, we could potentially be misdiagnosing them. And lastly, we're trying to bring these large data sets together with what's called federations. So once we have our data, we want to join it with other sets of data in such a way where we don't actually give our data to anybody, but we build this federation where the models are shared as they learn across the ocean, so that we build fair, explainable models that will work on a wide, broad population. So that's it. Thank you very much for letting me talk a little bit about what we do, and I hope that gives you some idea of how AI is used in breast cancer research.
Thank you, Dr. Shepard. So we have someone walking around with a microphone, so if you have questions, raise your hand, and we'll get to those. We've got one right up here in the front.
I want to thank you if you took off your mask to speak, because then I can see what your lips are saying. Otherwise, I just admire your pretty face. I have a question for each of you, but I will just ask a quick one of the cell therapy. Does the therapy need refreshing?
No, it does not. There are some cases where the cells will not persist in a person, and unfortunately, that can be a reason for the cancer to come back. In that case, generally, retreatment is not necessarily going to work. So the goal is that you would not need to refresh it.
Thank you. Next is a quick question. It appears you can amplify and delete. How this is done without damaging, or how can you amplify and delete without damaging or eliminating your desired sample parts?
Can you repeat the question?
Well, you had part of one of the cells said amplify, delete. And it's just part of what you're looking at in your circle of, maybe I'll ask you separate so that it's not confusing.
Okay.
The last thing is, when did you start using bias or being concerned with bias? Do you have a year when that was a concern?
I would say it started happening, or started being thought of when the algorithm started working, and then they noticed that it didn't work in some examples. And that's only within the last, like the paper that I think of, that's the kind of the definitive paper on explainability was 2017.
Yeah. So it started at what year? And it wasn't till 2017 that you noticed?
The very first examples of what we call deep learning, because AI has been around for, I mean, a long time, but deep learning where it gets a lot of success. I would say the very first success was shown in papers in 2012, but it took till 2017, 2018 to get into medical research.
Raise your hand
We
for
have-
other questions.
We have a
I've
question
got-
in the back.
Thank you. Hi, I'm glad you're all here today. How do you prevent with artificial intelligence, the data getting manipulated? Like if someone, we all have our hidden prejudices and some don't want to hide them, but anyway, how do you prevent that from happening?
I'm sorry, I missed the manipulation example. What were you?
Well, when you're entering the data, like I'm just using Hawaiian as an example, and how does it get, it not become manipulated in a racist way that?
Oh. Well, so sometimes you don't really know. It's very interesting that you don't necessarily know how it's getting its answer at the start. For example, we trained a model for melanoma and it was working fabulously. It was working so well. We thought we had done such a great job. And then we go, let's look at the images on which one it's getting right and which one it's getting wrong. And we found out that in the training data we'd gotten from dermatologists that when they had a suspicious lesion they thought was melanoma, they would always put a little ruler next to it so that it could measure the diameter. And so the algorithm only learned that if there was a ruler there, that meant melanoma. It didn't learn the signal of the melanoma at all. And so as soon as we figured that out, we slapped it and told it not to do that and took the ruler data out, and it forced it to learn the signal that was of interest. So the only way you can really understand that type of biases that I think you described would be to test it. You have to create test data to run the algorithm on and to understand, make sure it's not biased.
Question for Dr. Sidiropoulos. So President Biden suggested that in part because of the clinical trial that's going on with liquid biopsies for cancer detection, we might decrease cancer mortality by 50% in the next 25 years. So we want to get your thoughts on that as to whether that's an achievable goal.
I think it's potentially achievable if one of the things that I mentioned as a counterpoint to this type of testing is really there's this chasm, right? Where, and maybe some of you have dealt with this, where you might go to a direct to consumer genetic company like 23andMe, one of them, and you don't necessarily know exactly the ins and outs of what you're going to be getting. And next thing you know, you're told you have, let's say, a BRCA1 mutation. And what does that mean? And there's certainly, there have been women and men who have spoken about, opening their test result because, oh, they were curious, like how a story, for instance, that was published, how Jewish am I, right? But instead, now she got all this information and she has a serious breast cancer risk. So there's that moment of psychological despair, if you will, and trying to access the healthcare system, and then determine and track it down, where are you going to get your imaging and how are you going to work this up? So if you go with these multi-cancer early detection assays, you may be told, okay, you're at risk of having this particular cancer. But I think the problem right now is there's a disconnect between what these potential assays are telling you, but then how insurance companies then manage how they would help you pay for your care to determine where is that cancer, right? They're not, unless you have an official diagnosis, classically how we make it, you're up against it. So I think there has to be, we have to connect the dots there. And that's that missing link. That's that chasm that's so stressful for people that you really don't know is going to happen until you're there, unless maybe you're listening to a talk like this. So, you know, it's possible.
So we need to make sure that the Moonshot Initiative covers or forces insurance to cover people who may be identified as high risk.
Yes.
Which is not currently the plan. So,
Correct.
all right, we've got three questions going over here.
Am I next?
No, go ahead.
Thank you for this. I love the way that you each described your specialties in language that we could pretty much understand. So it's very encouraging to hear about better or more advanced detection methods as well as treatment. My question is, I was sitting here thinking of Star Trek and just spitting into something and learning everything about us. But my question is, do you foresee a time when this could become more of a screening thing? I've known more women in their 30s who are being diagnosed with 3C breast cancer, more advanced breast cancer, whether their lives are so busy they don't have time to do self-breast exams or whatever. So do you foresee a time when instead of going in for mammograms or bone scans or whatnot, that your testing modalities may be more of a screening detection that younger women and men could take advantage of? And again, thank you for being here.
Yeah, so I think the genetic testing is one possibility, using AI for screening, where you don't have to go through the process of going to the hospital, getting radiologists to read. You know, if we perfect that better, that maybe make it much easier for patients, maybe even home screening and using home AI algorithms. And of course, if you do get that cancer, you want your immune system to fight it. So we're going to go to Dr. Gerson for that last step. We got a question over here.
Yeah, so we have a question over Zoom from Betsy Morse. With respect to many people having cancers that will not be clinically significant, what are the estimated percentages of people who really do not have any cancer cells in their blood? And how is this affected by age?
Wow, that's a tough one. Does anybody want to?
What is the percentage of patients that do not have cancer cells in their blood? You know, I think that's a hard question to answer, because if we really think about how many mutations occur across our cells every day and how our different immune systems are able to fight that off, we're not screening people across just a wide population of people to be able to answer that question, you know, accurately. I think that's a fair statement.
Yep, there's two questions here. A quick one for Dr. Gerson before you get the microphone there. You talked about the CAR T cell for patients with lymphoma and leukemia. What is the response rate of CAR T cells for those patients? Because they've usually gotten lots of treatment before, compared to the standard therapies that we have at the moment.
Unfortunately, CAR T does not work for everyone. Most of the literature suggests that it only works in about 40 to 50% of patients. So we obviously have a lot of work to do. However, those numbers are in patients, just as you said, who've gotten, you know, every standard treatment and have really nothing else left for them. And so the hope is that as we move this therapy earlier and earlier in the treatment paradigm, where patients may even someday get it right when they're diagnosed, that the response rates will be higher and that more people will benefit from it.
Question over here.
Hi, thank you for being here today. In the arena of surveillance in patients that already had established cancers, how likely in the class of highly shedding cancer types will it be for liquid biopsy to replace scannings, MRIs, PET scans for ongoing surveillance?
Right, and no one wants to do that. That's not fun. So the hope is right? Is that we could implement this. And I think as a monitoring process. Again, I think it's a matter of there's still a lot of clinical trial data coming out around that. And there has to be cost effectiveness work that's done. So then again, the insurance companies, it's hard enough to get a lot of insurance companies to pay for genomic testing when it's necessary, medically necessary, never mind moving it into the sphere of them paying for it on an ongoing basis. So I think that work that's needed to be done to move it into that space is well underway. It's within the foreseeable future. I believe that that will come to be. And I will be thrilled for us all when it happens.
Obvious benefits in terms of exposure to radiation, et cetera, and so forth. But
Yes.
do you have any concept at this point of cost of doing a liquid biopsy versus, say, a nose to knee CT scan or a PET scan? Is any of that work been done?
I think, honestly, I do believe that the cost is probably lower to do it the way we're talking about in the foreseeable future. But I don't have the numbers off the top of my head, but I would imagine it's with the cost of sequencing decreasing, right? It's just like when you think about CDs or, you know, any technology, cell phones, that cost is going down. And the technology is only getting more sensitive. So it doesn't take as much overhead necessarily to do that. And certainly it's less burden on the patient to come in and go through the rigmarole. So I would hypothesize it's less.
So we're out of time. We had one question here. I'm going to ask you to come up and ask the panelists in a minute because we have to turn over for the next concurrent session that's going on. Let's give a big round of applause for Drs. Gerson, Sidiropoulos, and Shepard. Thank you.
Thank you all for being here. Just the note that there are exhibitors if you're shifting your space and going down to the Levesque Ballroom on the far side of the hallway, take a peek at our exhibitors throughout the day. Thank you for being here.